Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Mr. Chairman. I would like to thank Dr. Manal for inviting me for this conference, which I'm delighted to have a talk. My talk is regarding the Down syndrome growth chart. As we know, and it is have been discussed, that Down syndrome is the most common chromosomal disorders and include a combination of birth defects. And according to the National Down Syndrome Association, more than 400,000 cases of Down syndrome is recorded in United States. So why they are having a growth chart, or what is first? Let's go. Why? What is the growth chart? Growth chart is a tool to record the serial measurement. This is number one. Number two is a method of assessing the trend of growth. Number three, it is a way of comparing a child growth pattern to that of the population. So growth in children with Down syndrome, babies with Down syndrome are born at near term, usually not exceeding 38 weeks. They may take longer time than other baby to get their birth weight. As we know, there is physiological weight loss, then the gaining of weight starts. But in such cases, they have a longer period to gain their birth weight. Children and adults with Down syndrome tend to be short. They are having high prevalence of being overweight or having obesity, and their pubertal growth or spurt occur 1 year earlier than their standards, and it is less pronounced. So why a special chart for children of Down syndrome have been developed? This was started early in 1980s, and it was developed all through the years until we reached to the final RRCH, Royal College of Surgeons chart in 2012. Short stature, as we know, it is a well-recognized characteristic among the people of Down syndrome, with the average height at most of age is around the second centile of the general population. There is increased risk in the additional of medical condition like the congenital heart disease, like sleep-related apneas, and all these can be the cause of the decrease in the centiles, or it is an additional disease. Regular growth monitoring and plotting on the appropriate age can be early indication of the problem. So if I'm making my plotting and I can see that the baby is not going to the normal values, then we should interfere at this stage. As I told you, the growth chart started in 1988, and it was updated, reaching to the UK growth chart 2002, and even the UK growth chart 2002 have been updated twice, reaching to the final one, which is approved by the Royal College in 2012. The first one was having 5 centiles, as all the growth chart are between the 10th centile and the 90th centile, but it was updated to the 2nd centile, 98th centile, and the last one is 0.4 centile up to 98.6 centile. Sorry, 99.6 centile. So how they collected their data, or how they made the last growth chart, they retrospective in 2001, they retrospective collected the parameters of cases of Down from birth until 19 years of age in 16 districts in UK and 1 district from the Republic of Ireland. They excluded all cases with any congenital anomalies or congenital heart disease, including PDA. So if the baby is having a PDA, he was excluded from this study. Then in 2008, the Royal College commissioned to design a new preschool chart to incorporate with the new WHO standard. And it was done by a full program, train the trainer and supporting the education material. In 2010, they finished and they started implementing in Scotland, Wales, New Zealand, and Ireland, and it was approved. In 2012, it was approved by the Royal College, and it is implemented everywhere now. So what is new in this last growth chart? It is having many pages. The first page is related to the cases between 0 to 6 months. Then this to allow the more accurate plotting during this time of age. And the second page is the between the 6 months to the 4 years. And a final page which include the age between 4 to 18 years. As I told you, this chart or these charts, the final ones, contain the 0.5 standard deviation low line, and this will help to monitor the growth of exceptionally small children. So based on this, they concluded that no healthy child would be expected to be in this line. So the 0.4 standard deviation is not acceptable to have any baby or any case in that stage. Any child who is not already receiving medical attention and whose plots lie in this should have a further medical evaluation. And these are samples of the growth chart all over the development, reaching to for example, this is the WHO Royal College of Pediatric Child Health. This is the combined one between 0 to 4. This is the front page, and this is the back page. This is from the 0 to 18 years. And this is the latest one updated, as you can see here. This is 0 to 6 months, and this is 6 months to 4 years. So how to use this redesigned chart? Plot the measurement from the term age. Preterm babies, they are not plotted in this chart because they don't have data for this. Hence, they are using the N90 National Infant Close Monitoring Chart. The reference value are essential for assessing the linear growth, and however, as many older children and adults with the syndrome are overweight, the reference value for the weight should not be used as a standard that these children should aim to achieve. So we should not either accept the overweight, neither the underweight in the 0.4 standard deviation. Hence came the importance of using the body mass index, and the body mass index will help in evaluating or diagnosing the baby or the Down syndrome between the underweight, overweight, and obesity. So we are plotting the height versus the weight, and we can see here in the chart that this is the weight, this is the height, and here I'm having overweight. This is obese, and here is the underweight. So also this is added in the new chart. So what are the recommendations for using this charts? It is good practice to record and chart the height and weight frequently from the first 2 years of life on the revised chart. Thereafter, it should be made at least annually, then at regular interval in the adult life. Regular measurements are likely to be sensitive and early indicator of any medical problem, and should be over-represented to the population. Preterm babies, as I told you, will not use these charts. Will use the national neonatal chart because no published data for this. So the neonatal infant close monitoring chart will be used, and it is should be used until the 37 weeks of gestation. Thereafter, we will use the Down syndrome growth chart 0 to 6 months, then the 6 months to 4 years. But keeping in mind that our data for the preterm babies should be based on the corrected age. The newborn and young babies, babies with Down syndrome, they are prone for early weight loss, as we mentioned earlier, and they gain their weight later than their colleagues, maybe longer than 2 weeks of age. So if by 4 weeks of age there is no serious medical problem, most will be on the centile close to their birth weight. So if they didn't gain the birth weight by the second week, then it is a major underlying pathology should be excluded, and a full checkup should be done to exclude other congenital anomaly. Breastfeeding should be encouraged and supported, and here it is not just supporting the baby by the breastfeeding. It is most important to have a team working with the mother to support her and encourage her for breastfeeding, pointing to the importance of breastfeeding and bonding with her baby. What about underweight? Children below the second centile for the weight needs evaluation, but those who are less than 0.4 centile needs immediate intervention. So if they grow roughly parallel to their centile, this is reassuring. Even they are on the second centile, but if they fall at a lower centile, then they should have extra supplementary feeding and extra care and investigation. We mentioned that they are prone for overweight and obesity, and the appropriate anticipatory guidance regarding diet and physical activity should be given to the parents. Again, based on the body mass index, we will guide the parents on which track they will go. The Down syndrome specific chart clearly reflects the tendency to overweight among the UK study, and it is now implemented in many countries. Children over the age of 2 can be charted on the body mass index conversion chart, particularly if there is concern about the overweight. We discussed this, and a point of importance that we should concentrate, it is as it was mentioned in the previous lecture, the thyroid function test that should be done at least in the beginning with the accelerated weight gain. The puberty, we mentioned the Down syndrome specific chart suggests an absence of pubertal growth chart. They go into puberty before 1 year of their colleagues, but there is no the pre-pubertal growth spurt. These children do have an adolescent growth spurt, and it is usually less vigorous than general population. There is a doubt or debate about the use of growth hormone, and it is in case of Down syndrome for the growth, and it is not recommended to be used in all cases of Down syndrome. Final height is achieved earlier than the general population, and this can be one of the causes that they are shorter than others. If early onset of puberty occur, this is another adding factor that they will not reach their final growth or height. So take care. Chart are tools and need to be interpreted, to be used alongside the clinical assessment, to be used for the healthy babies, or to know that the healthy babies may lose more than 10% of their birth weight and take up to 4 weeks to regain their birth weight. After 4 weeks, most of the baby weight track within the normal centile, but pay careful attention to those who will not grow to the normal centiles, or they are growing slowly, or they are having feeding problems. Finally, a child with Down syndrome has more in common with every other child than they are different from them. Distribution of IQ in children with Down syndrome is as wide as in typically developing children. And finally, think child, not Down syndrome, see the person first, think different, not disabled. Thank you very much.